Hospital and Raheja Hospital. Dr. Parth has extensive experience in managing a wide spectrum of cancers. Today, Dr. Parth will be sharing valuable perspective on breaking barriers in MHSPC doublet, where darolutamide plus ADT leads the way with Aranode. Please join me in welcoming Dr. Parth Ganatra.
Hello, thank you. Thank you for the warm welcome. Yes, I've been using and I've been advocate for this molecule, and what we have seen the results is very good. So I would like to share my experience and the data in today's meeting. You can start the slide from share the slide from your end if possible.
Yes, sir. Yes, I can do so.
Okay. Welcome everybody to discuss today's data of darolutamide with ADT. Next slide, please. Yes. So as we say that the hormone-sensitive metastatic prostate cancer treatment has been showing some good results from as early as 2014. We got ADT with docetaxel, and then we had abiraterone, then we had enzalutamide, apalutamide, and so on and so on. And the latest contender in the field is the darolutamide, and we will see how does it help, because the thing is that with this advanced, before we had just ADT or castration, with the addition of other molecule, the results were good, but we would really struggle in the real life to manage the patient after the 3 years, because by the time the patient becomes the castration resistant and many medicines have been exhausted. So what to do to give the patients long term benefit? Next slide, please. Yeah, so this was unmet therapeutic need, that though we have good medicine, good thing, but how do we extend the patient's comfort, patient's life, and patient's response in a better way? So there was a Arasen study, phase 3 study, which used docetaxel, and it has showed beneficial efficacy and safety profile in the hormone-sensitive metastatic disease, and that is now approved in 2023. Now the thing is that with the result of Arasen study, there was a question that how much docetaxel is actually needed, and for that there was another phase 2 global study, Aranot trial, and with the Aranot data, darolutamide has potentially changed the treatment paradigm, and now it will be only the medicine which can be used with or without chemotherapy. And I would strongly argue that it should be used without chemotherapy, only darolutamide and any sort of ADT. Next slide, please. So, how this the concept came into the thing in Arasen study, the darolutamide was used with ADT and docetaxel, which demonstrated favorable efficacy and safety. So Aranot trial was decided to eliminate the need of docetaxel. Next slide, please. Yeah. So how this trial was designed, that first patient selection, it was randomized to 2:1, two in the study group and one in the placebo plus ADT group. The primary endpoint were standard like OS, time, time for patient to initiate the subsequent type treatment, time for the CRPC, time for the PSA progression, and rate of undetectable PSA, and most importantly, the time to pain progression, safety, and other this thing. After the primary analysis was done, the patient were crossed over. Everybody received darolutamide, and that has also showed benefit in the study, which we'll discuss later on. Next slide, please. Next slide, please. Yeah. So I would like to uh, 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 put your attention towards a little bit of salient feature of this study, because this study mimics a lot of real world scenario that we are going to see. First, there was the median age was 70 years. That is the most of our patient group. And what I'm very really happy to say in the trial is that the Asian population was almost one third, 30% or nearby 30% in the both group. because what we have seen is that the Asian population is little bit of underrepresented in many of the trials, and that's why we do not see the similar efficacy and safety that we see in many molecules. So yes, this trial had a significant representation from the Asian people. The metastases were in a majority of the patient. Some were de novo and some had a recurrence. And 70% patient in both group has a high disease volume. And the Gleason score was more than 8 in approximately 70% of the patient. So this represent our Indian scenario, the Asian scenario, where the age is little bit on higher side. Patient come with a metastasis, the disease volume is already high, the visceral metastases are there. Visceral metastases are not much seen, but sometimes we see, and most of the patient come with this kind of this thing. So this very well can translate into what we are going to see in our patient. Next slide, please. Yeah. So as we can see is that in the Aranot trial, the Asia, India, China, and this was gave a significant number of patients, especially India, which contributed around 13 to 14% of the patient in this trial. Next slide, please. Yeah. So first and foremost, the progression or the risk of death, there is a clear separation early in the curve, and as the time advances, the curve separates further. The median survival is not reached in the darolutamide group, where the placebo it was 25 months, and the curves stays separated as the time progresses. The hazard ratio of RPFS was 0.54. There is a with a statistically significant p. Next slide, please. Yes. So in all group, the data favors the darolutamide. Now we see the all age group, all baseline PFS, PSA, all baseline performance score, Gleason score, and especially high disease volume. In high disease volume, there is a significant good result in the darolutamide group. Next slide, please. And the secondary endpoint that is actually important for the patient, like when the patient is now labeled as a metastatic castration resistant prostate cancer, which was not the median time was not reached in the darolutamide group in the study, full study, the 25 month of the follow. The time to PSA was the time to progression was 20, 29, 21% of patient had progression in the PSA versus 48% in the placebo group. And time to initiate the treatment was very less in the study group. And more importantly, the time to pain progression, median was not reached in the darolutamide group, which was around 29 to 30 months in placebo group. Next slide, please. Yes, so this is what matters to the patient. The patient will be very happy to take your any ADT form you ask, injection or castration, whatever. Patient has no problem to take the darolutamide tablets. But the patient will be very, very affected when the patient has to take chemotherapy like docetaxel, cabazitaxel, or lutetium therapy, and this curve separates very early in the darolutamide, and it the gap widens as the time progresses, and the pain is something that hampers the patient's quality of life. In that also we see the curve separation, and on the longer follow-up period, 30 months and forwards, the curve stays more separated. So the patient quality of life, because of the less pain progression, is better in the darolutamide. Next slide, please. Yeah, so this is what we want to see, that the patient's PSA, which is non-recordable, which was 62% in the darolutamide group, while it was just 18% in the placebo plus ADT. And the time to PSA, as we see, is that there is nothing to say, because this curve says by itself that the time to PSA is in a minority of the patient, and the it doesn't the dolutegravir doesn't lose the efficacy after suppose like 1 year, the patient PSA is not progressing, then there's a very less chance that the patient has PSA will progress on a longer period of time. The curve becomes flat, while the patient who on ADT, uh, the the rate of progression is faster as the time increases, but the curve flatten out in the dolutegravir group. Next, please. Yeah. Now this is the thing that shows that how much good the daratumumab is. Low volume disease, we do not see in our practice, very less. Patient come with a high volume disease with metastasis and everything. In that age group, the PSA non-detectable is around 40% or more. 44% at 24 weeks, at 36 weeks is 47, at 48 week it is 50%, and on a longer time, almost 50, more than half of the patient, they have non-detectable PSA level. And the PSA level stays there, and there's not much of a recurrence in that. Next slide, please. Now, the patient who has required the progressive disease and they require any other treatment, uh, first of all, we have to see that who patient has discontinued the treatment was 71% in the placebo group, while it was 45%. And out of them, the 32% required second line of therapy. Now that is uh, because we have seen docetaxel, we have experience with docetaxel, so majority of patient went for the docetaxel. Some patient responded to abiraterone, and minority of patient enzalutamide, apalutamide, cabazitaxel, radium, which is not available in India, especially we have to import and all. And olaparib is depends on the patient's genetic, but the patient who required subsequent rifampicin systemic neoplastic therapy is 32%, while it was 42% in the placebo group. Next, please. Right. So now, with addition of any medicine, we want to look out that is was there any other treatment emergent adverse event? So it was almost similar in both of the groups. So we can say that the daratumumab doesn't add into the additional toxicity. It was 90% of any grade and 91% in the daratumumab group, and similar the grade 3 and 4 or grade 5 and serious adverse event. So they were very comparable. So we are not inviting any additional morbidity or any adverse effect while adding the darolutamide. That is something that is more important because these patients tend to be on a higher age group. They have other comorbidities. With that, if there is an adverse event, sorry, with that any adverse event, the quality of life decreases. So with the addition of darolutamide, there is no additional uh, adverse event that we are seeing in any of the grade. Next, please. Only one back. Yes. Only thing that what we can see is that hyperglycemia. Hyperglycemia is seen more in the darolutamide than the placebo. Otherwise, almost all the adverse event like anemia or arthralgia, UTI, back pain, transaminitis, constipation, they all are similar, comparable. The hyperglycemia was 3.6% in the placebo group and 6% in the this diatomer group, and it is very well easily manageable. Main important is that after we start the ADT, the patient complains of fatigue. uh, this most important side effect that patient's life is become restricted is less in the diatomer group, so it is actually favorable. Next, please. And other side effect also, it is not much of difference in the both of the arms, and all the side effects can be very easily manageable. Next, please. And uh, quality of life also improves. That lead to the ASCO 2025 presentation. The darolutamide extended the median time to deterioration the FACT-P total score by 5.1%, 5.1 month than placebo. The darolutamide is the first and the only AR inhibitor to demonstrate the clinical and meaningful delay in the pain progression, and overall well-being. And this 5.1 is a very important thing for the patient. Next, please. So, in all the quality of life parameters, the darolutamide is favorable in all of the parameters like physical well-being, social and family well-being, the urinary symptoms, the functional well-being. So, yeah, next, please. So, all in all, darolutamide ADT has significantly improved the PFS in the hormone-sensitive prostate cancer. That too, without needing the addition of the docetaxel. It has shown benefit across all secondary endpoints, and it main thing is that it is deep PSA response. It is not like transient and patient uh, have the PSA raised in much less time. It's a deep PSA response, and the pain progression, overall well-being is also very very favorable. So the patient's quality of life, patients the productivity of life also stays the same. So diatomite and ADT without docetaxel should become the additional standard of care for the hormone-sensitive prostate cancer. And with the help of the Patient Assistance Program (PAP), it is now more and more lucrative to use in our patients. Thank you. Next, please. So this was my data study with the license trial, and that can guide us and that should give us confidence in use many and many more and more patient with uh, elderly, with comorbidities, the high disease volume, and the higher glycine score patients. Now I would like to invite anybody's question if we have any.
Yes, sir. We have one question.
Yes.
Like the question is, if cost is not a concern, what factors would make you choose one ARI over another in first line in MHSPC?
So the ARI are the standard of care now. The patient should be given that. Now, cost is one thing, but when the cost is not a concern, then what we have to see is that how much longer benefit we can give to the patient. There is the only question that we have to answer. First is the longer benefit. Second is that is there any uh, quality of life problems like patient is having fatigue or any other side effect. In all parameters, when we see the abiraterone, enzalutamide, and darolutamide, the preference should be on the darolutamide because that has got longer plus favorable side effect profile. And the PSA undetectable has a very longer and deep response.
Right, sir.
So thank you for giving me this opportunity to share my data. We have used in many, many patients. And in when we say about the data, there will be any percentage. But as a practical point of view, I have not even seen a single patient whom we had to stop the darolutamide for the toxicity. And the patients are taking the treatment, they are living their life, not much of a side effect for the pain, because the pain consultation also reduces when the patient starts on the darolutamide. So, yeah, that was my practical that we have not even discontinued even a single patient for the any other side effects.
Oh, sir. Thank you so much, sir.
My pleasure. My pleasure.
Thank you, sir, for sharing your valuable perspective and your experience. I thank you
Mhm.
on behalf of Bayer as well, sir. Thank you so much.
Thank you. Thank you. Thank
Thank
you
you.
to everybody for attending. Have a good night.
Good night, sir. Bye, sir.
Thank you.
Thank you. Thank you, participants, for being present. Support team, you can close the meeting now. Thank you for your support as well. IT team.